Hello. Today we discuss bronchial asthma, a practical guide designed for daily medical practice. Bronchial asthma is a heterogeneous disease characterized by chronic inflammation of the airways, with symptoms such as shortness of breath and cough that vary in intensity over time. Asthma can be broadly divided into allergic asthma, often associated with eosinophilic inflammation, and non-allergic asthma triggered by infections or medications. In recent years, additional phenotypes have been described, including T2 high, T2 low, late onset, and obesity-associated asthma. We also recognize exercise-induced asthma, NSAID-induced asthma, and occupational asthma. For practical reasons in daily medical practice, I personally prefer to keep the classification simple: allergic versus non-allergic asthma. Exacerbations are defined as periods when symptoms worsen, or when treatment must be intensified to maintain control. Clinically, asthma most often begins with a dry, irritating cough that frequently occurs at night or after physical exertion. Later, patients may develop wheezing or rhonchi and a prolonged expiratory phase. In severe cases, a silent chest may occur. Using a pulse oximeter during lung auscultation can help correlate clinical findings more accurately. A key diagnostic criterion is demonstrating partial or complete reversibility of airway obstruction using spirometry. Reversibility is typically tested with a short-acting bronchodilator, or SABA. One limitation of spirometry is its dependence on patient cooperation, which can be problematic with physical or cognitive limitations. A normal result does not exclude hyperreactivity. If suspicion is high, consider methacilline challenge or cold air provocation. Peak flow meters are designed for monitoring asthma progression, not for the initial diagnosis. Pheno reflects allergic or eosinophilic airway inflammation, where bronchial nitric oxide levels are elevated. A pheno level above 50 ppb strongly supports the diagnosis and predicts a good response to inhaled corticosteroid therapy. Total serum IgE is generally not a reliable marker, because asthma inflammation is primarily localized within the airways. Body plethysmography is a useful alternative when spirometry is inconclusive, as it is less dependent on patient effort. Another alternative is the forced oscillation technique, the method least dependent on patient effort, though it requires trained personnel. The main diagnostic challenge is differentiating asthma from chronic bronchitis or COPD, especially in elderly patients. Key differences in chronic bronchitis include progressive rather than episodic symptoms and persistent airflow obstruction without true reversibility. Furthermore, chronic bronchitis typically presents with normal pheno levels and an absence of eosinophilia or hyperreactive T. Differential diagnoses include pulmonary embolism, reflux disease, heart failure, pulmonary fibrosis, and COPD. Inhaled medications are the most effective therapy because they reach high topical concentrations in the bronchi. Apparent non-responsiveness may simply mean bronchodilators are trapped in proximal airways and do not reach distal regions. Choice of device should consider the patient's abilities. In children under 5, metered dose inhalers with spacers are preferred. Asthma should always be treated in children to prevent impairment of normal lung development. Every treatment step must include a rescue medication used when needed, usually a short-acting beta agonist. Inhaled corticosteroids are the mainstay of therapy because they effectively reduce airway inflammation. While ICS may slightly slow growth, remember this principle: children cannot grow without oxygen either. As a general rule for adults, if a SABA is needed more than twice per week, inhaled corticosteroids should be added. Guidelines describe multiple steps, but for practical purposes, the escalation strategy can be simplified. In adults, Step 1 is SABA as needed. Step 2 uses low-dose ICS plus formoterol, and Step 3 adds a long-acting beta agonist. Step 4 involves increasing doses, while Step 5 adds LAMA and potential biological therapies. In children, Step 1 is SABA, Step 2 is low-dose ICS, and Step 3 combines both. Steps 4 to 6 progress to adding LABA, LTRA, and eventually LAMA, or biological therapy if necessary. Biologicals are considered after 3 months of failed maximal therapy, with reassessments at 4 and 12 months. Available agents include omalizumab, mepolizumab, and dupilumab, with specific age-appropriate indications for children. Acute exacerbations are treated with SABA and systemic corticosteroids, either orally or intravenously. Secondary measures include vaccination, reducing allergen exposure, weight loss, and smoking cessation. Thank you for watching this clinical guide. If you found it helpful, please like and subscribe for more technical series. Until next time.